Hello, welcome to this webinar on the Healthcare Home Model of Care Requirements. As everyone will be aware, that the new Healthcare Home Requirements came out in December. So there was always the thought of the collaborative to review the model of care after a year. And that's what's happened, and everyone has hopefully got a copy of the new model of care requirements. So due diligence was paid to the review of the model of care requirements. We sent out questionnaires to both members of PHOs and to clinical leads and to GPs and practices incorporating nurses and administrative staff. We also interviewed with some of the key players for the model of care requirements. Including, again, GP, nurse and PHO clinical leads. There were then some forums which took place locally with some questions asked and review of the answers. And then it was all taken back to a leads meeting where the whole model of care requirements were taken through so that we could make sure we were getting as much feedback as we could and taking on board everybody's comments and thoughts. So the key outcomes around that review, I think actually it doesn't say this on the slide, but actually one of the big outcomes was the need for a tool and resources to be available to everyone. And I think that should be top of the list because I think that was the most important thing that everybody wanted to get out of this. And that's coming along. We now have the model of care requirements online, which you can look at. We haven't quite got the resources sorted yet, but that's a work in progress. And hopefully within the next 6 months, we will definitely have more interactive online tools for you to use. So the other big area that was changed was around the better focus on equity. I think everybody was aware of bringing this on board with the healthcare home journey. And I don't think it's quite right yet. It has been introduced and we will happily answer questions on that later. But I think that you can see that we are trying to bring that in, but it does require even further kind of clarification and thought, and that's definitely top of our list for the next time of review. We're hoping that we've improved the clarity and reduced some of the duplication that was there in the model of care, and really looked at the impact on patients and practices. So I have a panel with me today to try and help me answer some of your questions. I'm Kirsty Lennon. I'm the lead clinician for the Healthcare Home Model of Care Requirements Review. I'm a GP up in Kapiti and also the clinical lead for to Ora Compass and also up towards the Hut and over in the Wairarapa. Today we also have Dr. Andrew Miller, who is the clinical lead and Healthcare Home Collaborative member up in Northland and Whangarei, and he has experience of the healthcare home model. Dr. John Morgan, who's GP at North Care, Thomas Road, Pinnacle Health, up in Hamilton, and John's practice has been in the programme for 8 years. And Melissa Simpson, who's the healthcare home programme lead for Ora Compass Health down in Wellington. So they're all here to help answer some of your questions, and hopefully we can give you some more clarification. So the point of the webinar today really is to help you to have that interactivity and find out what our thoughts are on some of the service elements. John is going to take on the clinical triage part and unplanned and urgent care. Andrew is going to take on and look at the equity lens within the healthcare home and the development of that. Melissa is going to take on the proactive care, and I will come back to you at the end with clinical leadership and extended care team. And then at the end, there's going to be the ability for a bit more open discussion. So please send us some questions. We have some planned questions which have come in through email, which we will take you through. But there will be time at the end to answer some more questions which come out of the webinar. So please feel free to tap those in and send them through to us. And if you're having any problems with this webinar, please, again, send us a message and we'll try and sort those out for you. And the panel will give us as much information. So I am now going to pass over to Dr. John Morgan, who is going to talk about telephone assessment and treatments.
Kia ora. As Kirsty's already said, my name's John Morgan. I'm a GP at the Thomas Road branch of Northcare. And look, I've been tasked with talking a little bit about what was previously called clinical triage or phone triage. And to point out some of the differences in this set of requirements from the previous. Just to frame it up, traditional access for acute problems proves difficult for the practice, and also, much more importantly, for the patient, frustrations around waiting and no appointments available, being sent to after hours, getting sent to ED, etc. for the patient. And from a GP's perspective, and also primary care team's perspective, unplanned, chaotic, causing a loss of control across the day. So traditionally, a difficult work stream for all involved. So look, a key bit of the change to the healthcare home model is to actually look at your acute flow, really get behind what the demand is and when that is, and to put the, okay, sorry, I've got a message that I'm having slight technical difficulties, but is that better? Hopefully. So get inside what the demand is, and to face up the patient with the most experienced clinician available, and the gold standard is that patient's GP who knows the patient best. One thing we've felt fairly strongly about is the term clinical triage is actually quite misleading in this setting, and we've changed the name of it to telephone assessment and treatment, in that traditionally triage is just assessing what the patient's level of need is and how quickly they should be seen face to face. We don't want to be doing that. We want to look at alternative ways of meeting patients' need in the most respectful and patient-centered way possible. And one of the spin-offs from that is that we create some capacity at a practice level. So that's again a really important difference between the assessment and treatment, just as opposed to triage itself, is actually some of the trials that have been done abroad on just pure telephone triage haven't shown much of a benefit. Again, we're going past that, assessing and treating patients, which is a key difference. Look, the other thing we've debated long and hard is who is best to do that clinical triage. It's getting away from the patient and the receptionist, so the patient debating and negotiating with the least trained and experienced person in the practice, who's it's frankly inappropriate to do triage or make any basis of acuity, etc. So to get away from that model and towards a clinician who can most importantly diagnose and prescribe at that time. So we're maximizing the number of patients who can be dealt with by phone in a timely and safe manner. And we've really look at that's basically the GP, and the gold standard is the GP that patient knows best. a nurse practitioner, or in some cases, a clinical pharmacist. Certainly at our practice, we've got a very able clinical pharmacist, and we direct some of the phone triage work to her if it's directly involved with their medication or spin-offs from that. Again, it's looking at the availability of that clinician in a practical time frame at the time of greatest demand. I guess most practices have a peak of demand at about 9 o'clock in the morning. Others vary. It's pointless putting your experienced clinicians to triage at 3 o'clock in the afternoon. So it's putting them in front of the patients when they're actually the demand is the greatest. One thing that we've experienced previously is that's not sometimes when it suits the practice, i.e. after all the appointments have been booked up, it's something that happens right from the get-go. Your call management system directs anybody asking for a same-day appointment towards that triage or the telephone assessment and treatment process, and it's picked up by the clinician who's responsible for that workflow at that time of the day. And that may vary from a GP for half an hour to 3/4 of an hour in the morning to and then handing over to a nurse when apparently I can't be seen. We'll work on that. So handing over to a practice nurse at lower volume times of the day to some of the bigger practices, ours included, have come to the conclusion that actually this is so important that we've got a GP responsible for triage throughout the day. So that sort of stuff's very much dependent on your demand and your practice size. So, and it's clinical triage or phone assessment and treatment throughout the day. So that's, I think, about. Oh no, there's another slide. I think I've touched on the fact that it needs to be based on data around when your demand is. There are most of the telecom providers provide a call volume report, and you can make pretty good assessments of your demand from that data. It's important that the person dealing with your calls is actually fully aware that it's that simple rule of anybody asking for an acute on the day appointment gets put through to the GP. Also important to collect some data out of the outcomes from that telephone assessment and treatment. That's important to make sure that you're making a difference. I'm pretty certain that it's really a good idea to get that down to a clinician level, and you can then support your clinicians who are maybe less confident in this field to feel more comfortable and actually then ability to treat more people without them needing to come near the practice. So look, that's probably all I had to say for now, unless any of the other. Andrew's pretty good at this sort of stuff. I could get that. Well, so I'll move on to questions. Good. And look, the clinical triage implemented in small rural practices. I think this is the question, that comes up a lot. Does it suit it to small practices? I think, again, it's just down to demand and need. Some of our rural practices in the network that are adopting this have had some huge feedback from their patients. Farmers who live way out in the sticks, who is hugely demanding to come into the practice, are some of the most grateful of patients if you can deal with things safely at a distance. I think there's some specifics around some of those rural communities where demand might be slightly later in the day. I think one of our practices in Artia, start their triage slightly later in the day because they just they realise that demand is low first thing in the morning because everybody's milking, and they've got to spike slightly later. So it's those sort of little intricacies. I think it's also around using the team you've got to the best that you can. So I think it's like whether it's rural practice or urban, it just depends on the size, but it's the principle behind it that you put the most experienced clinician in front of the patient at the time of the biggest demand. And on to the second one, again, the financial incentive or funding model. Lots of people initially very, very sensitive to this. It's, are we giving away care? And I think that varies whichever PHO you're within. Certainly Compass and Coast Health are using a fee for the triage or telephone assessment process. Melissa, nod if it's, I'm right. Yeah, and look, and any work that flows out of that is no extra, but except if they need to come into the practice, then the triage interaction is free. Other places, Pinnacle included, is that we don't charge for the triage itself, but any work that flows out of that, so an acute script or a med cert or a referral, is charged for. We've looked behind that, and actually 70% of those interactions over the phone that don't need to come into the practice are either they either generate a script fee or a fee for other work, or they're in patients who there is no co-payment either. So actually the amount of work that isn't attracting an income generating opportunity is 30% of the triage. We've also got some funding, flexible funding, that overarches the whole model, so it supports that 30%. I guess personally, if I was going to start again, I quite like the Compass approach of charging for the interaction and work, much as a face-to-face consultation. The work that's involved in that doesn't attract a fee. It's the act itself. So I guess individual practices need to see how those business models fit.
John, Mel from Compass, we don't have a standard sort of approach in terms of practices charging, so we leave it up to the practices, and it all depends on their, I guess, their business model and also their cohort of patients. So, yeah.
Cool. And I think one comment about this is that it's in some ways getting away from the fee-for-service transactional approach to the care, to the overarching business model and the funding that comes with it, and does that support it rather than it counting the individual widgets. That's a mindset that we've had to get into. Does anybody else have any? I think I should hand over then to the marvellous Andrew Miller.
Very generous of you there, John. I'm a GP up in Northland, the clinical lead here for neighbourhood healthcare homes up in Northland. I think we need to start actually looking at the facts that exist. Just to give you an idea, in Northland, in 2015, a survey was done about the well-being of Northland Māori in terms of health delivery. 40% live in decile 10. They are 4 times more likely to live in crowded homes. They are 21 times more likely to end up with rheumatic fever. 2,000 children in Northland have avoidable hospitalisation a year, with either through prevention or lack of early treatment. 80% more likely to be admitted with heart disease. 5 times higher heart failure admission rate, twice as more likely to be admitted with a stroke. For 75-year-olds, they're 4 times more likely to be admitted with a heart attack. This is the fact. So that actually is, at a broad level, is unacceptable. I mean, we have a ability, I think, to take that seriously and do something about it. I mean, healthcare homes obviously aren't an entire solution, but we can't wash our hands and say, oh, it's to do with social determinants, it's to do with things outside our control. We as health providers have a considerable lever, both inside our practices, but also as spokespeople and advocates for the people we serve. So inside our healthcare homes, we could actually lead some of the things that need to change to deal with some of those inequitable outcomes. So, you know, what matters to whānau, there are things inside the model of care about community and social engagement, about interdisciplinary teams, about how we do our care planning, how we actually figure our workforce with health improvement practitioners, health coaches, social workers, navigators, pharmacists. So we do need to step up, I think. At a obviously national level, there's work in progress about health and disability reviews. But if out of what we do as healthcare homes, it becomes apparent that we haven't got a fit for purpose workforce to allow what matters to whānau to be addressed, then we should be some of the advocates and spokespeople for the people we serve. That's in the big picture. The next level down is when someone presented to me a GP information report about the equitability in my own practice. It was sobering. We refer Māori patients less, we treat them less, we investigate them less, we offer them less services, and there's whatever bias goes on is unacceptable. Our practice's view of that inequity was initially a bit of shock, and then actually a very strong resolve to work on that, because we didn't think that was acceptable. And without that data, people make assumptions about how well they're doing. Clearly they can see at a population level there's things going on, but at individual practice level, that data should be a driver for pulling our socks up. We've got a little stuff there, these points here, 3.2, 4.1. These are elements within the new model of care related to equity. Cultural considerations in developing care plans. Really, our plan should be about what matters to whānau, what matters to them and their family, what their goals are, what they'd like us to do for them. There's plenty of models and whānau order models. There's wharekapa, there's quite a lot of culturally appropriate models. How you work your own care planning within your own area must take into consideration what works for whānau and what works for a view that makes them healthier and happier and focuses on well-being rather than on pure medical care. Reducing health disparities is a priority. Partly, I think we go back to what I've mentioned, is that unless you measure the disparities and then look at what processes you've got going on, both at a system level across the health system, but also within your own practices, it's really easy to sit on your hands and just say that's not my problem, or we don't have a problem. You know, so wherever possible too, we probably need to engage in a more open and collaborative way with our communities and our whānau to work out where they want to focus their energies in terms of wellbeing. The socio-economic, and in terms of issues with 6.1 is related to affordability. Some of that lies outside our ability to change in terms of how capitation works, but with other funding streams and situations where you've got Care Plus and other ways of working alongside patients to reduce affordability barriers, obviously you'd be trying to aim to do that. I think that comes again to us advocating nationally on behalf of our patients. And the 6.2 is still with cultural needs, which I mentioned. So then that folds into the routine and preventative care element of our model of care. I think I've already talked to most of these things already. One thing that you can do within a practice, even if we're saying that some of the social determinants are hard to resolve, we can immediately make a difference in terms of things like patient portal uptake, shared care, planning uptake, telephone triage, particularly for rural populations, Māori populations with poor roading, poor access to transport, is incredibly important. The other thing that tends to happen when you do telephone treatment is that you avoid any bias in terms of how calls are handled. They're handled in the same manner for all patients, with no ability for decisions to be made by anyone along the way to either not offer services. So my last bit here is just, how do we measure this element? It comes back again to data. I mean, I've given you good data from a northern wide region, but unless your healthcare homes organisation or within your practice, you can continuously measure every element that you're delivering in terms of equitable outcomes, then you'll either sit quietly thinking you're doing okay or not know if you're progressing. My own practice, we have quite a lack of information around this, and it's something we need to work on, because unless you measure it and you continue to measure it, you're not going to move. And I guess the last thing in terms of resources available to practices around delivering equitable outcomes, some of it is to do with how well we are working with community and Māori engagement. That's an element I think that many practices will get to as they progress. Initially, many of us have got bigger fish to fry in terms of getting to day-to-day workload sorted out. We also have to have a workforce that's fit for purpose to deal with some of the things we hear when we start asking people what matters to them. That needs to be reviewed nationally, in my view. Hopefully, over the health and disability review, some decisions will be made about having more access to the people that can be the levers and navigators for better outcomes. Locally, if you've got any way of advocating with your DHB around those types of roles or working with other organisations in your locality, obviously that helps. But even just within your practice, as I've mentioned, that some of the things you can do immediately with portals and the way you handle phone calls and who you offer shared care to can be done right now. So thanks.
Thanks, Andrew. Hi, as Kirsty introduced me, I'm Mel Simpson, so I'm the Healthcare Home Program Lead here at Tora. So that crosses Cape Coast DHB and Wairaka DHB. So I've been given the privilege of talking about Domain 2, which is proactive care for those with more complex needs. And essentially, what have we done in this domain? So we've tried to sort of refine it and remove some of the duplication and to sort of make it a little bit more succinct. So some of the service elements we've merged, and particularly, and I guess just to sort of explain a little bit more, service element 3 and 4, which is proactive assessment, care planning and care coordination processes are in place to support individuals, whānau, with complex needs. We've sort of merged that with people who are identified as high risk, have a named care coordinator. So we've made those two come together, so we haven't duplicated that further on in the model. Secondly, the characteristic 3.5 was moved to routine and preventative. And I guess as we move through the model of care requirements and we review it annually, some of the service elements or characteristics sit better in different domains. So we've sort of moved that one on, and that was about sort of health records and care summaries and health information, including clinical tests and the sharing of. So we thought that was probably better placed in the routine and preventative domain. And then we took out service element 5, and that was sort of moved over to routine and preventative care, and we replaced that with what we call 4 now, which is the practice proactively wants to achieve equitable health outcomes for all, especially Māori Pacific and high depth. So when we talked about having more of an equity focus in the new revised model of care, I think that's where that's how that relates to that one. I mean, I guess the key focuses of this domain, and we've gone from 4 from the old, after we've revised it, we've gone from 4 service elements and condensed that down to 2 and 10 characteristics. So before, this was quite a large domain in terms of characteristics, and we've sort of pared that back to 6. And so hopefully that is easier for practices to follow, and also for the leads and the like, being able to work through the requirements. And essentially this sort of domain focuses on risk stratification. So looking at those patients sort of with high needs, and predominantly what we look at is the top essentially the top 7% of those patients who are at risk of potentially having a hospital visit or needing sort of quite in-depth sort of support with their long-term conditions essentially. It also looks at development of care plans, and different areas of the country have got this a little bit more sort of, I've got more support in terms of enablers. So while some of us are still using paper care plans, and there's nothing particularly wrong with that, but we've got parts of the country that have got electronic shared care plans, which is the holy grail, if you like, which is the gold standard, which we're all sort of moving to, which enables care teams to come together and have a shared care plan, and most importantly, the patient is involved in that, and they can add to their goals, or they can update it as needed and become essentially part of the care plan, which they should. The patient should always be at the very centre of that in any case. And I guess the other focus of this domain is an interdisciplinary approach. So that's looking at your expanded care teams, and that's sort of within the practice but external to the practice, and involving particularly those community services teams, NGOs, and anyone else that is sort of part of the patient's or whānao's care team, and who the patient identifies as wanting to have them involved in their care. So we can flick on to the next slide, and I guess just some of the questions that have come up. And the first one was, what is the definition of an interdisciplinary approach, and what would level 4 look like? So I guess I'm thinking an interdisciplinary approach sort of involves different disciplines who will come together essentially either physically or virtually, and it could be a mixture of both. So we can see some areas where we've got MDT meetings, for example, coming together first sort of face-to-face for some time while sort of relationships are formed, and then moving on to a more virtual space and using sort of technology to enable more disciplines to come together around the care for a particular patient. And that also includes involving the patient in these discussions and meetings as well. And I guess it's them coming together to work collaboratively with a common purpose, and I guess the patient, what the patient wants and what the patient's needs are is essentially the core of this, to sort of set goals, make decisions, share resources and responsibilities. And I guess particularly this is the most important sort of area for those sort of older patients or patients with multi-morbidity and social and psychological needs. So having a range of team members come together to support patients. So that's what I would think is a level 4 sort of, and it actually involves who needs to be involved from a patient perspective. So you can have up to, you know, a number. Generally we'll find that these patients have got multiple people coming together to sort of support them, but we needed sort of like a platform or a way that they can do this sort of combine the approach, and actually everybody knowing what each other is doing and not duplicating resources and not confusing the patient, more importantly. So that's what I would see 4 would look like. And a care coordinator, so the model sort of, and we talk about extended roles in the model, but also extended sort of responsibilities within the team. So this is sort of a relatively newish sort of name since, particularly since we started the healthcare home program. And a care coordinator essentially is someone who's sort of identified within the practice, and it can be any member of the team, but typically I think the nurses within the practices sort of own this domain to some degree. Not to say that the GPs don't have a big influence, but I think generally it's somebody that the patient can identify as one point of contact who sort of holds the ring around the coordination of that patient's care, so they're not calling up multiple times talking to different people and they're not having to retell their story. So, and it's about having a relationship with a particular person that they feel that they have regular contact with. So a definition of a care coordinator is someone that the patient knows by name and can contact if need be, and also who contacts the patient at various times in the year, depending on what the patient's needs are. And the other one was about health plans and how they differ from year of care plans. So I think year of care plans look at proactively managing or supporting a patient for 12 months in advance. So it's sort of been more of a less of a reactive sort of approach and more of a proactive approach. And a health plan, I guess by definition, if we look at the model of care, maybe looks at your patients with less complex needs and looking at having some preventative and screening plans in place, such as cervical smears and mammograms for your sort of generally wellish sort of cohort of patients. Thanks. I'll pass over back to Kirsty.
Hello everyone, welcome back. Thank you, Mel. So I'm going to speak to you about clinical leadership and the extended care team. In my role as clinical lead, obviously I'm going into multiple practices. And so one of the areas that we looked at with the change of model was change management and clinical leadership being merged. So healthcare homes as a model is really a change management model. And without doing change management, we aren't going to progress. And so it was felt when we were going into practices, people were accepting that there was change management as part of the model, but if there wasn't good, clear leadership around that model, then it just wasn't working quite so well. And with good, clear leadership, the change management happened as a consequence of that leadership. So it is kind of written into the service element that clinical leadership is undertaken with regular training, which is important, but also that staff lead change. Now, I have to say, I'm not sitting so comfortably now with the word clinical, because I think actually the leadership can come from any member of your team, and it can be that there is good input from the lead GP and nurse, but also I have seen really a lot of progress when there has been good administrative leadership as well. So I think the clinical is a little misleading in this one, and I think maybe we will look at that again, because I definitely feel that it could come from anywhere. But the other thing that's important is that leadership is given time, that it isn't assumed that people can manage that change management within their normal time, you know, with fitting it in between our other work that we do, which, as you're aware, can be overwhelming at times and take a lot of time up. So I really feel that time should be given to that, and that there should be teaching and resources around that, which I think we are coming to as well, and that's one of the questions that I've got to answer. We all have to see general practice as a business, and without that, businesses will not survive without change. And we all know now that there are threats coming to us, including the online services given by other agencies. We're aware that there's recently been a pharmacist attached to a shop that then has bought in the ability to have virtual consultations with a GP within their facility. So we know that those things are coming, and if we don't change in response to that, then we aren't going to progress, and we aren't going to really look after general practice for the future, which I think still will have a very key role in healthcare. And I think if we look at the countries where it is succeeding, Denmark recently report around the fact that, you know, reducing the numbers of hospitals because their primary care is so good and supported. And I think that we can put ourselves there, but it takes some time and thought and progress. And if we think about Air New Zealand and booking online, you know, now we can order our meal, or we can order online entertainment without necessarily, you know, having to do that if we didn't want. So they have evolved with time. And if you think about those companies that you trust and kind of look up to, then you can see that their change management is in place as well. So I think it is key to this model. And I think, therefore, the important thing is that that change management is supported by good clinical leadership. Extended care team. So again, I think initially this really kind of was a very small part of the service element, but I think with time what we've realized is that expanding that to include a number of people has been key in practices where practices are developing in a, with this model in a good way. And so we've incorporated now clinical pharmacists, PCPAs, health coaches and social workers. I think on top of that could be psychologists. This is by no means a limited list. This list could be extended. Health navigators, I think Andrew and John mentioned those, where that's extending those roles so that, the key that you're working at the top of your scope and not having to do those things. So we do need to think about that, and that becomes part of then your business development around, well, actually, if we replace this person who's leaving with somebody else who does another job, who can maybe take the workload from the clinician, how does that fit in? But that takes a bit of thought, and it also takes time. It's not really something that can happen quickly, and we're certainly not suggesting you get rid of staff to replace them with other staff, but with natural attrition, etc. It's worth thinking about what other roles might help support your patients in their journey and their care. And that doesn't always necessarily mean it has to be a GP or a nurse at that point. So yes, so we have looked at that and really kind of incorporated a lot of other roles in that situation. I think I probably answered the first question where, change management is critical to the healthcare home implementation. I agree, it absolutely is, but it only works actually as part of good leadership and can only happen with good leadership. And in fact, it is still part of that characteristic because the leaders should be really using change management in order to progress the healthcare home journey. And it is a journey. We've always kind of said this, that healthcare home is not an absolute. Level 4 is not the gold standard. There is a standard above this. And this is just a way to learn change management and take yourselves through this model. And I think absolutely, and I've seen this already, there's a level 5, 6, 7 for some practices, which is way beyond what we're offering at the moment. So, I think be aware of that. And there's not an end point here. Resources, yes, I think we've been aware of this need for resources, I think, across the board with all service elements. And we are certainly developing the online tool with that in mind. And we have a list of resources that we're going to start to add to that so that people can look at them and use them as they need them. From the point of view of practice workforce development, my thoughts are definitely around trying to help leaders with some resources. So possibly a reading list, which I think might be quite helpful when you're starting the journey, just to get some tools that you can use within practice. Certainly we have resources from the lean process around change management and how that might look. And we've got some workforce development tools that we can use as well. Certainly within Capital & Coast, we have one for nurse workforce development. So that will be added to the website. And I think the whole healthcare home journey has really allowed us to share information and resource. And I think this is the first time, when we do Cornerstone, we all tend to sit in our individual practices and we all develop, our protocols and policies. But actually, if we shared really good work, then that's going to make everybody move forward quicker and easier and really get good practice out there. So I'm keen to keep developing that. As I say, I think we're looking at about 6 months lead in where we're gathering resources so we can add them to the website. So we're now going to move on to really the open discussion part of this webinar. And these are some questions that came in. So I am going to read out the question and then invite my colleagues to just open up and answer questions. I might ask them if they would be willing to answer this question. So question 1 is the characteristic 1.1 appointment system. Is the ideal to have slots for each GP each day? I personally would say very much yes. I think it allows for that continuity of care. I think if you've triaged the patient and you have knowledge of that, it allows your surgery to run in a much smoother fashion. I think the patient appreciates that they've spoken to you and then you're the one seeing them later. So I think it allows for that continuity. John, I don't know if you have any thoughts about that.
No, I look, totally second that, Kirsty. I think one of the founding principles was about continuity, about the relationship with the patient and the GP that builds over time. And actually, practically, if you've done a telephone assessment and you've not elected to treat the patient, you're bringing them in, then you're by far the most perfect person to do the face-to-face consult, because you've done most of the work already. One thing that patients feedback is that they hate having to repeat themselves, and so from a patient's perspective as well, it's much better to come and see the person who you've talked to on the phone. Again, a knock on from that: how many acute slots should you have on your template? Again, that's down to demand and getting a really good understanding of the data behind, and that will be there'll be some seasonal variance to that as well. Anybody else got any comments?
No, okay, I'll move on to question 2. Thanks for that, John. The requirement of extended hours could be difficult to implement for VLCA practices due to financial viability. What are some of the recommendations? Andrew, do you have some comments around this area?
I guess when you're doing financial modelling, when you're going into healthcare homes, there's a bunch of different elements we need to have in the model of care to make it work properly. So extended hours is one of a number of variables, and so practices doing the maths of what it costs to run huddles, what it costs to not have people being seen when they're doing triage and the like, that just gets factored in. I think many practices find that when they extend their hours, that it doesn't make as big an impact to their finances as they thought it might. It also depends on what the patient population of the practice wants. So when you go out and ask your practice population how your current hours suit them, some practices are finding that the patient's comfortable. So we're not demanding extended hours, we're actually asking for extended hours to be matched to patient demand. But until you do the actual finances on that, that's a difficult question to completely answer. But for many places, it's not proved to be an issue at all.
Perfect. Thank you, Andrew.
I think just on that, I agree with what everyone said. Some of our VLCA practices, and not only VLCA, but in terms of having to put in additional resources, what they've found is they can just stagger the start and finish times of their existing workforce. So some team members are quite happy for an early, sort of like a late start and a sort of early finish. So it's also talking to your staff members just to see if there's an appetite for that. And I agree with Andrew, it has to be done in correlation with what your patient population are requesting within reason.
Thanks for that, Mel. So I'm going to move on to question 3. What are some examples of the variety of formats through which pre-work is undertaken? Well, I think all the GPs could probably answer this in turn, but for me, it is around using the appointment scanner. I think it is also key that you have a robust recall system in place that can identify patients for work that they might need doing, including blood tests, smears, etc. But I also do take a bit of time, and I know in other practices sometimes it's the PCPA who just scan patient notes for missing indicators or what are they coming in for. And I know that up in Hamilton this has been taken a step further, so maybe John can speak a wee bit about that. But certainly for me, it's certainly about scanning my appointments, seeing who's coming in, and then on the day looking for what needs to be done. And I know that a lot of people do use the huddle space to talk about this so that people are aware of what might be needed for each patient. So, John, do you want to speak a wee bit about what's happening in your practice?
Sure. Right from the get-go, we looked at this pre-work concept, and we've divided into two sort of different work streams. First is pre-visit, so the work that goes on before the patient actually gets to the practice, and then pre-work that happens once they're in the practice, pre-consult. So pre-visit and pre-consult work. The pre-visit work, initially we trialed doing and this is a very American term, fishing consults, where nurses would go through each of the attendees for the couple of days in advance, contact the patient, find out whether they're coming, and put some stuff in place to plug gaps in their healthcare and their proactive needs. Wonderful concept, but it was just really, really tough to implement. Tough to get through to patients at times of day when our staff were available, and then actually it didn't seem to really make much difference at the end of the day, so we scrapped it. There is some talk of revisiting that and seeing if we can do it better, but the pre-visit work that we now do is a lot of what Kirsty's already explained, is around looking at the opportunities that come out of looking at the patient prompt for each patient, the day before the patient comes in, socializing those gaps at the huddle each morning, so that everybody's aware, and we can then work as a team as to how we do that. If somebody needs to smear, making sure there's a resource available to get that done whilst the patient's in. If you then go on to the pre-consult pre-work, that actually comes out of the rooming process, done by medical centre assistants, and that's going through a set standard work of collecting observations, giving brief advice for smoking, signing people up for the portal, talking to them about other proactive stuff. So that's, I guess, how we do it.
Andrew, do you have anything to add?
The only other bit of pre-work we do is after we are doing telephone triage calls. Obviously, there's a great deal of satisfaction in being able to get people to go and get the required investigations prior to arrival, or to arrive pre-consult to get something done in the practice before you see them. The streamlining of that and the ability to have results in front of you when you're seeing someone you've spoken to is incredibly satisfying for both the patient and ourselves. So that bit of pre-work is probably a bit that I wonder now why we never did that before, because we didn't have a good system to save us all this grief of people arriving. We send them off to the lab, we have to look at wait results to come back and get them back or talk to them. It's one of the things that really is great about doing triage.
Thank you, Andrew. So number 4, and we'll move on to facility infrastructure in 18.3 and 19.1. I agree, both of these are slightly similar, but I think the difference is potentially having workspace away from clinical rooms is in 18.3, and then more around potentially the running for looking for team work in 19.1. So potentially they're offering 2 different things. Certainly 19.1 for me is more around the teamwork aspect of a shared space, whereas 18.3 is just a workstation where a person can go to free up clinical space, rather than using the clinical room, so that we are maximising the clinical space as much as we can. John, do you have anything to add to that?
Thanks, Kirsty. No, look, I'd looked at that last night, and I think it was very much what you've said. One's about the facility and the physical space. Secondly is about the teams using that space as in a team environment, who's best to do the job and cooperating. So
thank you, John. Okay, so the other next one is around workflows in practices. Mel, do you want to have a wee speak about workflow?
Yeah, I guess in terms of workflow, it's about sort of looking at a lot of things, like patient flow is particularly one area that you could look at. Also workflows for teams. So if an example, I guess, is what does it look like for a patient who's presenting with an acute, who walks in and has an acute need, how does the flow of that patient go through the practice, and which team members are responsible for each touch of the process, and making that known to all. So I sort of say, it's sort of like if you had a new person on the team, how would they know, is there something documented or is there something written down? How would they know how the work flows through the practice for any given, like you could also apply that to patients who coming in for a year of care visits, or how does that flow through the practice, and who are involved in that process. So that would be my interpretation of workflows for practice teams. You can also look at, I guess, patients, like I guess the request for prescriptions is also another workflow, and how many touches of the process is that done by different members of the team. And I guess when you put that lean lens on that, it's about how can you lean out that process, and also once you've done that, making that sort of a standardized approach that everybody is sort of following the same way, so a reduced sort of variation, which reduced sort of wastes and errors, I guess, and makes a better patient experience when they turn up for something, they get what they've come for.
I think this would be an area where we would add a resource factor to the website with some examples. Mel, don't you agree?
Yeah, certainly, like 1-point lessons are a good way of sort of documenting different areas of workflow, and also it's also open for review. So revising those 1-point lessons once you've done them once, it doesn't mean that they need to be revised. If someone's got a better way of doing something, then yeah, active revision of them. It's a good visual and it's an easy one to follow.
Thanks, Mel. Can I just reiterate that you can send questions through either through the question and answer or the chat. We've had a couple of questions through, but not many. So if you want to ask us anything, please don't hesitate to send anything through. But I'll keep going with the ones that we already have. So number 6, which domain would we start first when implementing healthcare home, and what is the best practice? I don't think anybody would agree that there's a best practice. I think the PHOs often have some requirements from practices around the first things that they start with. I think probably urgent and unplanned care is probably the biggest part of that most practices start at the beginning, but very much the model fits together. So for instance, you really kind of have to start implementing your portal and getting patient and some workflow through that at the same time that you are starting to consider clinical telephone assessment and treatment. And my experience is that that's probably where most practices do start it. Interesting to find out if anybody had any other thoughts or differ from that view.
Oh,
Andrew?
sorry, John here.
Oh, John. Hi, John.
Oh, sorry, Mel was trying as well, but I think exactly what you've said is it's not just doing one thing, it's actually having to kick off a lot of this stuff at the outset. I think the standardization of rooms makes a big difference. I think some of the other lean stuff or continuous improvement supports the whole thing, so you need to start that early. Chats around patient portal registrations and getting that as high as quickly as possible is really important, and the acute flow stuff. The one thing I would say is that for the proactive care domain, to do that takes quite a bit of time, and that's quite a lot of nursing time, and I think that needs capacity to be created, and a lot of the things that I've already talked about actually have a knock-on effect with creating nurse capacity. such that once it's there, they can grow that proactive care domain into routine workflow. The key, I think, is that you don't wait to implement the proactive stuff, but you keep it at a low level within the resource you've got. One of the mistakes we made was actually leaving that till later, and it was harder to get it going again. So I think it's just keeping an enthusiasm for it, but at a low volume until you've created the capacity. Mel.
Yeah, I agree, John. I think starting with the, and I guess every practice comes in a different, depending on where their level of maturity is, when they enter the program, they'll come with different strengths and challenges. So we sort of do tend to start with the acute domain, only because there were a number of practices that we identified that they had such a large amount of patients walking in. They are up to some practices, you know, up into the double figures walking in daily, which actually did affect their third next available or time to be able to see a routine bookable appointment. And until we addressed that first part and looked at their acute demand, both on the phone and walk-ins, they were in a position that they were always going to struggle to be able to book a routine bookable appointment in a sort of satisfactory time frame, if you like, for patients. So we tend to start there, but I agree, we sort of do look at some of the quick wins for the practices, which are things like the 5S's and getting their team boards up and running, and the huddles or the stand-ups are also important. And the proactive care domain, which John sort of talked about, that does tend to come, you know, a few months down the track, and I think that also is influenced by your readiness of your community services teams, or your the DHB, for want of a better words, pushing out their community team members to be able to engage in the likes of MDT meetings and shared care planning. So that sort of, we found that sort of needed to come together before we could fully explore that domain.
Mel, a question has come through about timeframes and maybe putting some timing on it. Do you have any advice about that?
Timeframes on
implementing certain service elements. So, I mean, my thought is within the first 3 months, you should consider around the triage and definitely start portal from the beginning. And maybe, I know that for Cap Coast, it's, you know, we have to think about extended hours within that first 3 months as well. That's not the case all over, but also kind of John's thoughts on the proactive care for high needs and the care plans. I think most practices have come to that around the 6 month mark, I would say. But do you have any other thoughts on the timeframes?
I think the timeframes are also dependent on the practice and the level of depending on what's going on in the practice, is a sort of significant transformational change. So it's very difficult to put a time frame on each practice. They're all so different and they all move at different speeds, as we all know. But I think we tend to, within the first 3 months, we sort of really like practices to have a good look at increasing their patients on the portal as much as possible and opening up as many functionality parts of the portal as possible. But we tend to sort of do the urgent, unplanned clear within the first 3 months and get that sort of nailed as much as we possibly can, get the GP triage certainly up and going within that first 3 months. We look at extended hours, getting those, because I guess we thought as long as, you know, the longer you sort of leave it, the longer it will take to implement. So some of those extended hours, patient portal uptake, GP triage, certainly we look at those within the first 3 months and then move on to the rest of the program. But it's all done sort of in synergy, I guess, in terms of some of the lean stuff as well. So we've got the practices have a lean implementation plan that sits alongside their healthcare home implementation plan. So they sort of can pick and choose about which parts that they want to start on. So the practices have to have some ownership about what times and what periods they start different parts of the model. So yeah, it's not sort of a directive from us, but it's more where they're willing to start. And it all, like I said, it depends on where they start in the program as well. Some of them have got really mature sort of long-term condition programs already in place, so that proactive care, and if it's always been a nurse-led activity, they find that less of a struggle than practices that's typically been a GP-led model, because then we need to talk about nurse training and getting them back up with confidence about care planning, and yeah, so I think it's practice dependent.
Thanks for that, Mel. I'm aware time is moving on, so I'm going to move through quickly because there are a few questions coming in. But please be aware that if we don't answer your question during the webinar, we will try and answer them afterwards through email, etc. So I'm just going to keep moving. So the next one is around risk stratification needs. And apologies, I'd muted myself by accident. So did everyone get the message that please, if your question isn't answered during the webinar, we will answer it afterwards via email, but I'm going to try and keep going so that we can answer as many questions as possible. So risk stratification, again, interested, maybe Andrew, you could answer this around risk stratification, and if there's a high number of patients with mental health issues who are not on their risk stratification point, do their year of care plans count towards their year of care numbers? I think in CAPCOS we've definitely agreed that there is clinician discretion, and if these patients are high users of services, then absolutely they would count towards that. And a question has come in about the risk stratification tool. Should it be developed at practice level, PHO level, or DHB level? And does inconsistency in tools used create inequitable access, or does waiting for a high level tool become a rate limiting step? Andrew, you've got some thoughts on that?
Yeah, I've got some thoughts. I mean, risk stratification can be done a number of levels. It can be done from data in terms of those most likely to end up admitted, and that's being done quite in a similar way across New Zealand, and we're looking at the collaborative level to standardise that type of approach. It's also done, I guess, through our normal clinical flow, knowing who our patients are that most likely would benefit from year of care planning. I think we're missing a bit, though, completely with our year of care planning and risk stratification, is that there's no use working hard with people that are disengaged or overwhelmed with their life in general. So coming back to what matters to whānau and what matters to people in terms of their well-being, that the hard numbers of who may be most likely to be admitted or who may in fact have medical conditions that would be amenable to better management comes down to whether patients can engage with what we'd like to do alongside them and their families. So that's a bit of work with patient activation, I think, that we should be considering closely as we work out how to best use our limited resources.
Thanks.
Can I just butt in very briefly?
Yeah.
Look, we've been very clear with our practices that it's actually, there needs to be a great deal of flexibility, and it comes down to the clinical team actually making the ultimate choice as to who should be on that sort of high needs journey through the practice, if you like. And I think that the point in question 7 around mental health issues, intellectual handicap, all of these sort of things, traditionally really poorly picked up by any risk stratification tool. And it's much more around need rather than risk. And I've got some very high risk patients who have low needs, and people who are traditionally at low risk who have a huge amount of need. So I think that's a key bit. And my personal view on if you're going to use a stratification tool, it's silly if everybody does different stuff, and a standardized tool across the healthcare home world in New Zealand should be a goal.
Thanks, John. Okay, so we'll move on to question 8 around care plans and how you share that with other healthcare providers, and is this through share? I think to a degree it's through share. I think in this area technology has been a bit slow to catch up with what we are wanting. But some of the new PMS systems that are being rolled out do have the ability to share with other healthcare providers. And I think probably key to that is potentially share within the primary healthcare team, but also potentially also with anyone who's involved in patient care. John, have you got some thoughts about that?
Sure. I think at the moment, the ability to share that health information is relatively limited, but actually there's a great deal of development going on with a central health record, which the patient can then choose who they share different pieces of their health information with, be that members of the primary healthcare team, a multidisciplinary team, secondary care, family members, and I think that's going to develop relatively quickly, hopefully. Certainly in the indices space, that's one of the work streams that they're looking at pretty hard at the moment, and I think that's when the health plans for those patients with high needs, really the rubber really hits the road, when you can share that information easily and everybody's on the same page.
Just to let the participants know, the Healthcare Homes Collaborative is actually taking a national lead on this. We're having discussions with health information standards setters, Ministry of Health, and we have a concern that as many vendors are trying to roll out their own various types of shared care plan, there'll be no interoperability. So people transferring from one part of the country to another will leave a well-developed and well thought through care plan behind, because there's no GP to GP transfer of that information, because there's no standard set. It's very likely that there will still be multiple systems in New Zealand. There won't be a single electronic health record, but we will hopefully have a recommendation to vendors that if they're going to write care plans, that they write them in a way that's an open source way of doing it, so that both information can be viewed from separate systems and transferred between systems seamlessly. We are very much at the moment led by vendors and how they think we should be doing our work, and it's about time that if we're writing checks to vendors, that they do what we as the purchaser get them to do. So no one was doing this work. The collaborative's taken it on because we see that getting this right for patients is really important. So it's a work in progress, but we're going to be fairly ruthless about making sure that patients and we as providers have a better run at this than we currently do.
Thank you, Andrew. I'm actually going to skip the next two questions, because I think question 9 was answered very much by Andrew when he spoke about the equity service element. So I think there are more pressing questions coming from the floor, which I think is important. So one of the questions that has come up is around, does anyone have a good system for remunerating commission-based GPs? And really appreciate any ideas we've got on this. My personal thoughts around this are, I think you have to look at your business modeling. If we are looking at potentially moving forward with how we deal with patients in multiple formats, then that very much the commission-based income is probably a little outdated and probably needs reviewed. And I know this has come up in several practices around, you know, well, how do we move on from here? And I'd appreciate the input from the other GPs, because I'm not a business owner, but how they've managed it in practice.
Hi, John again. Look, we've moved away completely from incentivizing volume and number of patients per day, because that's, I think, a really difficult thing to do and stick to the principles of the model. I think if you're remunerating purely on the number of patients seen, you're going to incentivize people being brought in, the bums on seats model. And we've gone very much to a sessional fee, but also some expectations of, with those locums and or salaried docs who, you know, expectations of what work looks like for them. And that comes back to a discussion about the standard work for a salaried or locum GP. Andrew, have you got any thoughts?
Yeah, our practice has a bit of a hybrid. We've had salaried GPs, sessional GPs, and more long-term associates who are on a more of almost a fee-for-service type of arrangement. It hasn't made much of a difference. So we would consider, if someone's doing healthcare homes work and they're on a fee-for-service type of arrangement, that we pay them the full adult fee for that 15-minute block as if someone had come to see them and paid over the counter. And obviously the ones that are on sessional rates or salaries, they're working in that hour to do whatever work needs doing. So we've managed around it. It hasn't been any issue particularly. So if they attend a huddle, they get paid as if they'd seen patient. If they do triage, the same thing. So again, when we financially modelled, we worked that through in terms of loss of revenue over the counter and the time taken to do the various elements, and the maths of it worked out.
Yeah, I think it is an issue for practices, but I think you do need to have a think about it and just find out what is right for you. But I think as we move, and part of healthcare homes is moving away from that very traditional face-to-face consultation, for instance, shared medical appointments, etc., that you really do have to think about how that might be remunerated to your GPs. But thank you. Question 11, I'm going to quickly answer. So are wait times for the patient where the patient, are wait times the time a patient waits to get an appointment, or the time they wait when they attend for an appointment, or maybe the wait time for a callback for clinical assessment? I think, to be honest, they are probably all of that. Certainly in CAPCOS, we are looking at the time to next available appointment, but the specific service element is around the wait time for the patient within the practice. And that's not the time that the patient arrives, but the time between the patient as appointment time and when the patient is seen. So that if the patient arrives 40 minutes early, then, that's not within your remit to change, but the time the patient waits after their appointed slot is potentially an indicator of how smoothly things are running within the practice. And so very much that service element is around the wait time of patients within practice. But I think the other areas are just as important, and we should be monitoring things like your time back for a callback or for answering an email, for instance. So I think those things should be incorporated in it, but particular with this service element, we're looking at wait times within practice. Does anybody have any comment around that, or is that pretty much how everybody sees it? Yeah, I think so. Okay. So character 8.1, a fully functional portal. What's the level of practice where no access for clinical notes or to appointments online? And some multi-sited practices share a database and clinical staff and have had issues with opening appointment booking because patients can make appointments to see a GP who is not at the clinic the patient is expecting. Yep, I agree, this is probably some issue, but it might be around which appointments you open up. I don't have a multi-site practice. Do you, Andrew or John? Is there any comments you can make around that?
No, I don't, and the current portal is what we've got, is as good as it is, and there's many functionalities that it could greatly improve. So we, again, as customers of these services, should be asking the vendor to consider improvements to their product to make these type of issues go away. And they're a frustration to patients and a frustration to providers, and we should have some control over their research and development, or the place they're going to in the future.
Yeah, look, we operate multi-site, and there's a challenge to opening up appointment templates, especially if GPs work across the two sites. The one way we've mopped that up is to work with the vendor to actually make it explicit at where the patient is where the doctor is that day, but also text to remind message actually clearly stating where that appointment is going to be. Doesn't work perfectly all the time, but it does work. So there's ways around it, and I take Andrew's point with it is what it is at the moment, and patients really, really value the availability of booking online. The question of access to clinical notes, again, not related to multi-sites, but I think practices are certainly nervous about opening up full clinical notes, but I'm a massive advocate for doing that. Nothing bad happens. It cleans up your database. It actually reduces your work, and patients love it. So that's just my push for that.
Okay, so I'm going to make this the last question. I know that there are a few questions we haven't answered, but as I say, we'll be happy to answer them via email following the webinar. And also just to remind you that the webinar will be available on the Healthcare Home website, www.healthcarehome.org.nz, and you can go and have a look at the model of care there as well. But we will answer question 13. At level 4, should practices have documented processes, policy or procedure to support each characteristic? Or is it acceptable for them to say a process is in place? My personal thought around this is that actually I don't think healthcare homes should be ownersome with around paperwork. I think this is about your practice development. It's very much in the interest of your practice to move forward to the level 4. I think we have enough policies and procedures that we have to write up for Cornerstone. And I think that in no way should this model kind of be, have that kind of paperwork workload put on it. It's very much around developing your business. It isn't around proving that because it's on your advantage to be at a level 4. I think there is processes in place, or there will be, around certification and accreditation, and there will be some minimal requirements around some proof of what you're doing in that situation. But very much, I don't want, I definitely see this model as not one that should be labour intensive with policy or procedure. How do you feel about that, John?
100% agree. Actions speak louder than words. I mean, I think it's important to have standard processes in place, but whether you've got multiple documents to prove that doesn't really matter to me. I think it's just looking for outcomes rather than anything else.
Thank you. Andrew, any comment?
I mean, the collaborative itself, where policy or procedures or one-point lessons or things that can actually stop practices having to do the legwork themselves exist. So that's on a very pragmatic and practical sense. I couldn't agree with you more. This is not about a box-ticking exercise. This is about teaching practices to learn how to progress from across the model of care, and we're adults and we've got responsibilities what occur in our businesses, and we should be treated like adults and be responsible. So I'm a very disinterested in box ticking exercises.
Yeah, I think everybody has agreed it's we take it on high, we take each other on high value, and it's a high trust environment that we operate with. The healthcare home and the collaborative are happy with that as a process. So definitely not going to take it any further than that. Okay, so we are going to close the webinar. I'd like to thank Melissa and John and Andrew for helping me in taking part. And as I say, we will try and get back to people around those questions that they've posted, but hopefully you've got a lot out of this session and we've clarified a few things for you. And happy healthcare home journey. I hope you all enjoy it. I think we have definitely enjoyed the process. It's a model that I definitely love and love taking it forward. So thank you very much for joining us.